Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello, I'm Amy Goodrich, a nurse practitioner at the Johns Hopkins Kimmel Cancer Center in Baltimore, Maryland, in the United States. Welcome to this program titled Mastering Oral Therapies in CLL and MCL, Essential Strategies and Insights for Nurses. Joining me today are Claudia Bolinole, registered nurse at the Department of Hematology in the Careggi University Hospital in Florence, Italy, and Natasha Bolanos, head of membership and alliance at the Lymphoma Coalition in Madrid, Spain. Welcome to both of you. In this activity, we are going to talk about oral therapies for patients with chronic lymphocytic leukemia and mantle cell lymphoma. We're going to talk about management. We are going to cover non-adherence and how that impacts outcomes. And then finally, we are going to discuss supporting patients to optimize outcomes in patients on these oral therapies. So let's dive into these oral therapies and managing adverse events. So just as a background, CLL and mantle cell are relatively rare in the grand scheme of oncology. They are distinct conditions. They do share some biological and clinical features. The treatment landscape has changed significantly, mainly due to our oral therapies, our B-cell lymphoma 2 or BCL2 inhibitors, and also our Bruton's tyrosine kinase or BTK inhibitors. And as we have a growing number of therapies available for these patients, it is even more important to tailor to the patient's prior therapies, their remission duration, and also their preferences. And so we talked about BTK inhibitors as being one of the novel therapies that has revolutionized these diseases. And so let's jump into these. So we have 3 covalent BTK inhibitors available in both the United States and the EU. Ibrutinib is our first generation covalent BTK inhibitor, and acalabrutinib and zanubrutinib are our second generation BTK inhibitors. And they can be used in newly diagnosed patients or in the relapse refractory setting. We also have in both the United States and the EU for relapse refractory diseases, our non-covalent BTK inhibitor, pirtobrutinib. And so let's look at these drugs. So they can be given, our covalent BTK inhibitors can be given as single agent or in combination with our anti-CD20 monoclonal antibodies of obinutuzumab or rituximab, as well as venetoclax. And pirtobrutinib is currently approved in both the US and the EU as monotherapy only. So what are the common adverse events with BTK inhibitors and how are these managed? So I talked about ibrutinib being our first generation, acalabrutinib and zanubrutinib being our second generation covalent BTK inhibitors, and pirtobrutinib is our non-covalent BTK inhibitors. And you can see from this caricature the off-target effects, and this is where many of the side effects come from, are these off-target effects. And you can see that as a new iteration of these agents come available, they tend to be more selective and have less off target effects. So it's this inhibition, off target inhibition of TEC that contributes to bleeding and cardiac toxicity. And then those of you who work in the solid tumor space, you know all about EGFR related rashes, diarrheas, arthralgias. Though that's an off target effect of our BTK inhibitors. We are not meaning to hit EGFR, but they do. And looking at an overview of BTK inhibitor toxicities, we talked about bleeding. And then some of our cardiac toxicities, atrial fibrillation and hypertension, are seen with BTK inhibitors, as well as some ventricular arrhythmias. Those are very rare, but those also are seen. Arthralgias and diarrhea and rashes we talked about with EGFR. And then patients can develop infections, cytopenias, fatigue. These are some of the major toxicities that we see with BTK inhibitors. And so this is showing you just sort of almost as a class effect, cytopenias, which are common to all of them, some sort of diarrhea, whether how much of that is EGFR and how much is BTK inhibition, we'll sort out as time goes on. All of these drugs, my arthralgias and myalgias, and then you can see from there in general and this is the order of approval, first generation, second generation, and third generation. You can see in general there are less side effects as drugs have come to market. What about serious adverse events? So these are very low volume, but they include hemorrhage. So minor bleeding is very common. Hemorrhage is uncommon, but it is a known side effect, serious adverse event of these drugs. We talked about atrial fibrillation and atrial flutter, and our highest risk folks are males 65 and over with any cardiovascular history, particularly atrial fibrillation or hypertension. We talked about infections, and those can be severe, including opportunistic infections. The cytopenias can be severe. And then there is an emerging and growing body of evidence regarding second primary malignancies. And you can see that all of these drugs carry a risk of second primary malignancies. Most are non melanoma skin cancers, but a host of malignancies have been seen in patients utilizing these drugs. So, how do we manage these toxicities? So, atrial fibrillation is truly managed as if a patient were not on a BTK inhibitor. So, there's nothing special about the management. It is recommended that if anticoagulation is required, a non-warfarin option be used, just because the half-life of warfarin is so long, and if patients develop bleeding, that can become very problematic. And then rarely do BTK inhibitors need to be discontinued because of poorly controlled atrial fibrillation. So we talked about bleeding, and it's usually minor. One of the biggest things is for patient education is holding the BTK inhibitor 3 days or 7 days before and after procedures of any sort, any invasive procedures. I have patients hold, for example, 3 days before and after dental procedures, but something like a knee replacement surgery would be a 7 day hold. I talk about this every time I see a patient and remind them to just let me know if they're having a procedure done, and I'll let them know the hold time. But this is something that really needs to be talked about over and over and over again. Diarrhea, use over the counter antidiarrheals. Headaches typically are initial side effects that get better in a month or two. Usually, acetaminophen, caffeine help those, and just make sure patients are avoiding NSAIDs again because of that bleeding risk. And then hypertension, you That exactly as you would if the patient were not on a BTK inhibitor, depending on their other comorbidities. Hypertension is a unique side effect in that all other side effects or adverse events from BTK inhibitors either reduce in frequency or stay flat while patients are on it, but the risk of hypertension goes up, and it's usually years into therapy where this is commonly seen. It can happen early, but it's usually something that's happening as patients are on therapy longer. And it can be either treatment emergent, meaning new hypertension, or worsening of existing hypertension. So, Natasha, our BTK inhibitors are often used to treat patients with CLL and mantle cell lymphoma. What would you say are the main factors that influence treatment choices for patients?
Thank you, Amy. That's an excellent question. And to explore what drives treatment choices for people living with chronic lymphocytic leukemia and mantle cell lymphoma, I'd like to start by grounding these in real patient insights from our Lymphoma Coalition's 2024 Global Patient Survey. This is a large biennial survey offered in 20 languages that captures the experiences and priorities of more than 11,000 patients and care partners worldwide. And it helps us understand what truly matters to them when making treatment decisions. But not only that, it's how they seek information, what kind of support they wish and what they receive, how they weigh the trade off between side effects, quality of life, and clinical outcomes. So in 2024, we got 1,266 respondents with CLL that have had treatment and 350 respondents with mantle cell lymphoma. And when we look at what the data tell us, we see which factors patients said were most important when choosing their treatment. Patients don't prioritize just one thing when it comes to treatment goals. They value three outcomes equally. And these are improved long term survival, achieving a remission or a response, and maintaining or improving their quality of life. So these tell us that success for patients isn't just about extending survival. It's about feeling well enough to enjoy that extra time. And this fundamental insight directly shapes how doctors should approach treatment choices like BTK inhibitors to ensure they personalize the decision. So the first step is to align the treatment with the patient's treatment goals. And since quality of life is important as survival, we must look closely at the side effect profile. And we see here that patients are also looking for fewer or more manageable side effects during treatment. So, how treatment fits into their daily life truly matters. For example, if a patient worries about cardiovascular side effects or they have other comorbidities that makes this a higher risk, we may select a BTK inhibitor with a different risk profile so we can achieve response without compromising that daily well being. But another important factor is the treatment modality itself. For some, having a continuous daily oral therapy is the best fit for their lifestyle. But for others, they may prefer a time limited fixed duration treatment. For some, treatment at home truly matters versus treatment at clinic. And we see here small differences, but still important in the percentages of patients with CLL versus patients with mantle cell lymphoma. So these are the kind of conversations that bring shared decision making to life. And I don't want to forget to mention support context counts too, because patients are also looking for reduced impact on caregivers. Patients want a blend of survival, remission, preserved quality of life, balancing side effects, and practical fit, with care, partner impact, and confidence in evidence that could help them shape the final choice.
Thank you, Natasha. That data is fascinating. and very, very helpful. So let's move on to venetoclax, our BCL2 inhibitor. So, Claudia, how is venetoclax used?
Hi, Amy. Oh, yes. Venetoclax in CLL is approved for use in patients with either newly diagnosed or relapsed refractory CLL in the US and the EU for the same reasons. And it can be taken as a monotherapy or in combination with rituximab, as you previously mentioned. Instead, for MCL is not currently approved, even if the latest guidelines are open for possible therapy.
Great. And so, what are common adverse events associated with venetoclax, and how can these be managed?
They are common and severe. The common adverse events that you can see with another many chemotherapy. You can see cytopenia, diarrhea, nausea, upper respiratory tract infection, myalgia, pain, fatigue, and edema. When you talk about neutropenia, if you have a grade 3, 4, this can occur in the 40% of patients with a single agent of venetoclax, but increases when you take it with like an SDC20 monoclonal antibodies like rituximab, and increases more to 70% when it's used with the BTKI. But the rates of febrile neutropenia are typically low, about 3 to 5%. Instead, a series of adverse events with venetoclax and CLL is a tumor lysis syndrome that we will talk about, like TLS. What is TLS? TLS is when a large number of cancer cells die within a short period of time, releasing their content into the bloodstream. So, for patients with CLL who follow the 5 weeks dose ramp and take prophylaxis and monitoring measures, the rates are really low, 2%. But if you don't pay attention to all these things, it could be a high percentage. So, fatal and serious infections such as pneumonia and sepsis have occurred, and you should monitor for signs and symptoms. What are the risk factors of the tumor lysis? So, when you start the venetoclax, you should dose the increases, the run period. You should monitor. You should see if they have a decreased renal function, if they have splenomegaly, or if they use it with other drugs. So you should check with the lab abnormalities. Usually, you should see if they increase potassium, uric acid, phosphorus, and if they have decreased calcium. These are all risk factors. And then you should really measure the lymphocyte count, and so you should schedule pre-treatment labs to include TLS panels. So with the complete blood count, the comprehensive metabolic panel, uric acid, and LDH. So how do you manage venetoclax adjuvants? Depends on what you have. So if you have a tumor lysis syndrome, you should give excuse me for my English, anti-hyperuricemic agents, IV fluids, furosemide, sodium polystyrene, and you should avoid calcium-containing postpartum binders. If we are talking about neutropenia, we should give GCSF and even consider a drug hold. If you have a grade 4 neutropenia, um, in, and then restart at the same dose. But these are things that usually in Italy is a doctor that decides. When you have neutropenia, you should consider even a prophylaxis with levothyroxine, but it depends on the, for us, always in Italy, on the hospital guides. Uh, So when you check with the neutropenia, you have to be careful that you have to think about infections. So should tell patients to avoid to have contacts with sick people. Um, Maybe prior to therapy, see if they have all their vaccination, and even check the immunoglobulin levels. And then for the mild and manageable gastrointestinal toxicity, um, that can be diarrhea, nausea, and bloating. We can suggest to take this medicine with high-fat meal or little snacks during the day, or you can manage with um, like over-the-counter therapy, like loperamide or ondansetron um, for nausea.
Great. Thank you. And so, Natasha, do you find patients are less willing to take medications or be on therapies with the risk of more severe adverse events, such as tumor lysis syndrome?
You hit one of the most important part of the conversations, but let's reframe it. Instead of talking about the risk of severe adverse side effects as tumor lysis syndrome, that many patients won't know what it is, we must talk about how this treatment may make you feel day to day and what we need to watch out for. So we are moving here from the medical terms to what a patient actually feels and experiences. When we do that, we see that patients are often more willing to accept serious risks and side effects if they understand them clearly and they know for how long these adverse effects will persist, and they feel well supported and informed. But the side effects that truly shape their decisions are the ones that impact their quality of life. So, if we talk, for instance, about this specific tumor lysis syndrome, in medical terms, it's a metabolic emergency, as Claudia explained, caused by cancer cells breaking down too quickly. But for a patient, what does that feel like? They may experience nausea, vomiting, feel completely exhausted. They could have muscle cramps. In severe cases, it can lead to seizures or kidney pain. But the key here is that this specific side effect it's often preventable and it is manageable. So when we explain to the patients that there could be this or any other severe side effect, but the medical team will be watching the patient very closely in the first few days to prevent these bad feelings and to monitor closely and do any intervention required in case it appears so they can offer management strategies timely. It becomes a manageable risk and it's not anymore a mysterious terror for the patient. I already show how our survey data shows that patients value their quality of life just as highly as they value living longer. So when they ask themselves, will I be able to live a life or will I just be treating my cancer? So, in summary, patients are often willing to accept this risk of a severe, especially if temporary, side effect like tumor lysis syndrome, if it's managed proactively and if they receive the support they need.
Great. I agree with you. Thank you. So let's move on to our PI3 kinase inhibitors, idelalisib and duvelisib. These PI3 kinase inhibitors are not currently approved for mantle cell. They are approved in both the United States and the European Union in relapse refractory CLL, and also the EMA has approved it in first line CLL with high risk features, either a 17p deletion or a TP53 mutation, not eligible for other therapies. Duvelisib is approved as monotherapy by the FDA and the EMA for relapse refractory CLL. So first line idelalisib in the EU, and then relapse refractory in both of our approval processes. And so let's talk about adverse events with PI3 kinase inhibitors and how they're managed. And we are not commonly using these drugs. And really in United States or the European Union. Um, and it really is largely because of side effects, and what I like to see here, this is a very, data heavy slide, but we're talking about itises. So, colitis, transaminitis, pneumonitis, dermatitis. So these have a autoimmune component to them. There's manipulation of T cells there's impact on T cells with these drugs, and so lots of itises. This side effect profile really is why we are not using these drugs more commonly, but they are on our recommendations, so they are out there. But let's jump into lenalidomide, which is a much more commonly used drug. And so, Claudia, do you want to talk about how we're using lenalidomide?
Yes, Amy. Lenalidomide in CLL is not currently approved by FDA or EMA for use in patients with CLL. Instead, for lenalidomide is approved for MCL patients with the refractory relapsed MCL, but after two prior therapies, one of which has to be bortezomib.
Great. Yep. So mantle cell in this patient population, yes. And so, what are common adverse events, Claudia, that are associated with lenalidomide, and how are those managed?
We have even here neutropenia, tumor disease syndrome, which we already spoke about. But one kind of adverse event that is not very common in other therapies is the tumor flare reaction, which is a temporary sudden worsening of a cancer symptoms that occurs after the start of certain treatments like lenalidomide. So you should monitor during each physical exam and follow up for the sudden swelling of tenderness of the lymph nodes, low grade fever, and rise in white blood cell count. So how can you treat them? You can treat it with ibuprofen every 4 to 6 hours without need to discontinue or dose reduce the lenalidomide. Um, but the severe tumor flare reaction may be treated even with corticosteroids. At that point, maybe you should consider the interruption of the drug. Um, it may also require some opioid like morphine if you have pain. Another typical is rash. You can monitor during each physical exam if they have rash. It has some grades. It goes from grades, and you can manage with topical radiocortisone and antihistaminic. Or if it's more high grade, between 2 or 3, you can consider oral steroids and interrupting the dosage. Another interesting adverse events is a thromboembolic events. So you have to monitor for potential signs and symptoms such as shortness of breath, chest pain, or peripheral swelling. Um, so we have to provide thromboprophylaxis, and it has to be individualized mm, basic on the patient, but it can be usually aspirin if you have low risk patients, or if you have high risk patients, you can use heparin or warfarin. Other common can be infection, fatigue, and gastroenteric complications.
Great, thank you. And so, Natasha, what would you say are the overall patient centered side effects associated with taking oral therapies?
Mm, Yes, when we look at the patient experience data from the Global Patient Survey, it's clear that physical side effects remain a major issue, with 95% of patients with mantle cell lymphoma and 90% of patients with chronic lymphocytic leukemia experiencing physical side effects. In both mantle cell lymphoma and CLL, fatigue is consistently the most frequently reported side effect. So thanks, Claudia, for flagging that as well. And this is impacting around 60 to 65% of the patients. That really underscores how treatment impacts daily energy levels and functioning. What's particularly telling is when we look at which side effects patients say that they have the greatest impact on their quality of life. And here we see things like sexual and intimacy problems, fatigue again, and hair loss ranking very high in mantle cell lymphoma, while infections, sexual issues, and memory loss or appetite changes are especially burdensome in CLL. I would like to expand a bit on fatigue, which clearly stands out as one of the most challenging issues for people living with both lymphoma subtypes. Is both a symptom of the disease and a side effect of treatment with a deep impact on daily life. So when we look at how often fatigue is discussed, the conversation isn't happening as much as it should. So only about 1 in 4 patients said they had the opportunity to talk about fatigue a great deal with their doctors, while the largest group, so around 4 in 10 patients, said this happened only to some extent. And what's particularly concerning is that many patients don't receive meaningful support to manage, even if they report to their doctor. So, about 4 out of 10 patients of those reporting fatigue they said they received no help from their healthcare team. So overall, fatigue remains an under-recognized and an under-managed issue, but it's one of the main factors shaping patients' daily well-being and the sense of control of their illness. Um, Continue building upon this, we have used the AQ5D5L. This is a standard quality of life measure which looks at mobility, daily activity, pain, and mental well-being. It's an ERTC tool as well. And the 68% of patients with mantle cell lymphoma and 56% with CLL reported difficulties in at least one key area of daily functioning within the past months. The top challenges include loss of strength, pain or discomfort, and anxiety or depression. When we look at what patients describe as severe or very severe, the picture becomes even clearer because in mantle cell lymphoma, nearly half said they can no longer do the activities they managed before diagnosis, and about 1 in 3 report severe loss of strength. In CLL, the pattern is slightly different. So here, pain and discomfort are more prominent, with 3 in 10 patients reporting a severe impact from the pain and the discomfort. And anxiety and depression affect around 1 in 4 patients in both diseases at severe levels. So even though oral therapies may be perceived as less intensive, the lived experience shows deep functional and emotional challenges, especially around strength, fatigue, and daily activity. And finally, I want to mention the emotional side effects that are also very prominent. 83% of people with mantle cell lymphoma and 78% of patients with CLL said they experienced emotional effects related to their disease in the past 6 months. And the most common feelings here are fear of relapse and concerns about being immunocompromised. As you can imagine, in mantle cell lymphoma is the fear of progression, the one that is the strongest. Over half of the patients report this, and in CLL, the dominance is the concern about being immunocompromised, and it's almost 1 in 2 patients. We also have observed worry, anxiety, and sadness that are common in both and follow closely by depression. When it comes to support, only about two-thirds of patients with mantle cell lymphoma and just over half of patients with CLL said their medical team offer emotional support recommendations, and fewer than half of the patients actually follow those recommendations. So emotional well-being remains a major and often under-addressed part of living with lymphoma, especially the constant worry and uncertainty about relapse and infection.
Wow, thank you so much for that content. That's so helpful and so interesting to me. Um, so let's move on to understanding treatment non-adherence. And so, Claudia, what is the prevalence of non-adherence among patients with CLL or mantle cell receiving oral therapies?
Amy, unfortunately, studies suggest that between 20 and 40% of oncology patients on oral anti-cancer therapy show some degree of non-adherence. In CLL and MCL, the rates vary between 15 to 35%. It depends on the regimen complexity, on the side effects, and of the duration of the treatment, of course. So, because the challenge is big, it is a self-management regimen, so they rely only on them, you know? And over time, depends on the symptoms and adverse events, you have some adherence decreases. This is why it's common, under-recognized, and clinically significant.
Yes. Oh, I could not agree more. Natasha, do you have additional thoughts on non-adherence?
Well, it's difficult for the patients. We know that patients don't report always what they do to their doctors. And there are several reasons behind that. For some treatments, there are like strict rules they need to follow. So we know that, for instance, some young patients may skip in some moments the medication, although they don't always will have that conversation with their doctors. Um, so and the issue of the adverse effects, it's also something that some patients struggle if they don't receive like a proactive question to report on this. They may be skipping medication because they find very difficult to deal with the side effects they are experiencing, but they are afraid to report this because they don't want to be left without any treatment. So here, that's why the communication, the flow in the communication, and to have a proactive approach from the medical teams. And here, nurses have a huge role because they can really take this in their hands to promote those conversations.
Yes, I agree. And so, Claudia, how does non-adherence impact outcomes for patients on these oral therapies?
We have clinical outcomes because if you don't take the therapy, the efficacy of the treatment is reduced. You have a short progression-free survival, of course, and you can risk drug resistance. And from instead system impact, you increase hospitalizations, emergency visits, and healthcare costs. Instead, from a patient point of view, as Natasha said, we have emotional distress, fear of guilt, and reduce trust between the healthcare providers. So, nurses need to early identify and support because we can prevent all these mm, clinical and personal consequences.
Yes. And so, Natasha, is non adherence something you ask about in your patient surveys?
We haven't asked this directly with that terminology in previous global patient surveys, but this is a focus area for the next survey that will be launched next in January 2026.
Then, what would you say are the factors that, the barriers that prevent adherence, and how are you addressing those?
Yes, here I want to go back to the data of the Global Patient Survey, and this shows how patients want to be active partners in treatment decisions. So, the ideal for many is shared decision making with the doctors, and the strength of that preference differs. We have seen, according to the data, that 45 percent of patients with CLL, that means close to 1 out of 2, versus 39% in mantle cell lymphoma, which is a bit less, prefer patient and doctor together. There are also preferences for patient only decisions, and these are the same in both groups, 21%, so 1 out of 5, and doctor only is also similar. There are still patients that think, no, 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 I prefer my doctor to make the choice and to recommend me what they think is best for me. Eh, One notable difference is how patients want or not to include their care partner alongside the patients and the doctor. This is more common in mantle cell lymphoma, and it's not high, it's 17%, than in CLL, that it's less, is 12%. So despite the strong preference for partnership patients, doctors, the choice is often limited in practice, I want to raise, because one thing is when you ask the patients, who would you ultimately like to make healthcare decisions and choose your treatment? And another thing is when you ask, were you given the option, to do that shared decision making, or were you given more than one treatment option? And here we see that only 28% of patients with mantle cell lymphoma versus 29% of patients with CLL were offered more than one treatment option before their most recent treatment. And so, in 66% of patients with mantle cell lymphoma and 63% of patients with CLL were not given the options. So, as a takeaway, I would remark that patients show a stronger appeal towards shared decision making with clinicians. Um, in mantle cell lymphoma, there are more patients that often want their care partner also included, but both groups in real life frequently lack real options at the point of choice because they are not offered these options.
Well, thank you. Thank you. And then, Claudia, what do we know about barriers that affect adherence?
The barriers are so the lack of the family, financial burden can be an issue in America. Limited understanding of the disease. Maybe they don't really understand. Sometimes you have to translate what the physician said. It's a different. It's difficult sometimes to reach the hospital to the follow up, or maybe they have to take multiple pills because they don't have only cancer, and then so all these pills all together is becoming too much. The adverse events is, I mean, it's when you have so much diarrhea, so much fatigue, um, you don't really understand why you should go on. Um, and then you have to say, I can eat this, I cannot eat that. This can be a barrier.
Got it. And Natasha, how can patient and family needs impact treatment adherence?
Yeah, I think that it's pretty similar to what Claudia raised. I would add that we mentioned before the fear of relapse, the fear of being immunocompromised, the dependency on a care partner, and it depends on the patient characteristics here. So depending on the level of support that some patients have and how difficult it is to adhere to the to the treatment needs in terms of when the medicine needs to be taken, what are the rules behind that. We know that for some medicines there are like some other recommendations given, so that complexity may in patients that probably has less health literacy level, or do not feel sufficiently informed and lack the good understanding. And Claudia mentioned that. So we need to ensure that family needs at the end is understanding, is facilitating, following the medication needs in terms of scheduling, in terms of doses, in terms of side effects management. Claudia mentioned also out-of-pocket costs, or sometimes logistics, difficulty getting the medicine, lack of transportation in case there are medical appointments in the middle, conflicting work schedules. So imagine older patients that rely on a care partner, but that care partner needs to continue their work schedule, can be a significant barrier. So we need to ensure that patients receive the right information, the right support, and we can facilitate tools to follow the complex regimens of treatments that may require multiple daily dose, specific timing, difficult administration. Um, eh, so it's about considering the patient and the care partner, not recipients of care, but truly partners. And that's why we need to involve them early in these conversations and understand well their needs and preferences.
Yes. And then, Claudia, how can nurses identify patients who may be at risk of discontinuation of oral therapies?
Nurses, may when they don't come to the appointment, that it can be, uh, mm, you can see it, no? If they don't come, you start to say why they're not coming, why they didn't come to take the pills or refill it, or if you see that when you ask them, you can see a low degree of motivations. So this could be an alert. I mean, you can use some tools, give them some diaries, and maybe um, you can read them with them, and so to assess the key points, let them see where they start to change. So and then maybe you can ask them to bring them back the pills and count them, so you can see with them how they maybe misunderstood the therapy. And then maybe assess with them some quality of life skills, and so they can tell you with this strategy where is the problem. So it's always you have to always find a nice space where they feel secure to speak with you. You have to engage them with how you say in English, trust. And maybe start the questions, and let them open questions, so you can start to understand how they answer to you, and maybe then go on with the flow. So when they start to express frustration, when they start to report that these side effects are frequent, um, because it happens sometimes that they have like adverse events, so they stop. But sometimes they stop even because they feel good, and so they don't need this medicine anymore. And then, as I said, maybe financial barriers, but here is not the problem. Maybe it's more logistic, as said Natasha, because you need to go to the hospital pharmacy to get these medications. And if you don't have anyone that brings you there, pay a taxi for this is expensive. And then caregivers, maybe if I am 50 years old, my mother is 70, has to take oral therapy, but I have my family, so the caregivers and it is in an imbalance in their life. So, and sometimes the parent doesn't want to give too much frustration to, and so says, no, okay, I can do it without by myself. So nurses have to listen and use strategies.
Yes. And so what are the strategies that can improve patient adherence when they're taking oral therapies?
So the strategy could be to use motivation interviews. So uh, as I said before, ask open questions, create a safe space where they can be really comfortable to speak with you, not being judgmental because we are all human beings and we all have worries. Um, maybe um, translate what the physician said to them because sometimes it's this we have to be translators and maybe give them other strategies to manage the pills, no, adjust them with their lifestyle. um and so maybe they want to go to a travel, they want to travel and they don't know how to do it. And so you can give them skills to do that. So, as I said before, you have to have communication techniques. These are not things that you learn at school, you learn with life, you learn with experience. And you can ask uh, teach back method to confirm that they understood. So you explain and then you let them explain back what they understood. Um, then you can, we have like WhatsApp group with some patients. Um, we don't have a nurse-led clinic, unfortunately, but with some, we don't have virtual visits. We have telemedicine, yes. And then we have to be truthful. You have to uh, maybe set realistic expectations. So, what is the worst one? We can adjust with that, and then follow for more, and then they use simple language, really their language. Uh, so it becomes really easy for them to understand. You can involve even the pharmacists, you can involve social workers, you can ask for even for the psychologist if you want, if they if you think that they need it before ask the patients always. And then maybe really gently explore financial situations, transportation, insurance, because even spiritual beliefs, because it's not easy to speak about these things. Then you can give brochures um, to read. Some websites where they can advocacy, um, and then maybe do a self decision making, a self monitoring, like diaries, as I said before, and that's it. Most of all, I mean, and then try them to understand to come to the visit. So this is really important to come back. And if you don't, call me and we can adjust it. So this is what I usually say.
Wonderful. Thank you. I think what we've talked about here today is that oncology nurses are uniquely positioned to assess and non judgmentally discuss and address these barriers to adherence with our patients with CLL and mantle cell on oral therapies. And then I feel like you have both very eloquently exemplified how maximizing adherence leads to longer time on therapy and improved outcomes. And so, Claudia, what is the role of nurses in supporting patients with adverse event management and treatment adherence?
Nurse has a pivotal role because we are the one who administer. We are the one who um, we have a holistic, as I like to say, an holistic view. So we know how to identify and manage the adverse events, and how can we truly detect. We educate patients. We document whatever they do, and um, and we ensure that their voice is heard. So as we said, the adherence is one of the strongest predictors of treatment. No, if they don't take the therapy, everything fails. So our role is to support the patient, to be practical, and to so we can try to maintain the adherence.
Great. And then in terms of optimizing patient-centered care, we have really talked about strong communication, using shared decision making. Some other things that are helpful are these standardized adverse event reporting tools, regular multidisciplinary team meetings and huddles, clear follow-up on who is responsible for what, shared electronic care plans. And so, Natasha, in terms of optimizing patient centered care, how can the healthcare team, including nurses, ensure that patients and family needs are identified and explored and allow for that individualized treatment?
Thanks for the question. And I think that the best is to identify first what is not working well. So, because I'm truly convinced that nurses can fill in those gaps. If we evaluate how communication sets the tone for patient centered care, our survey shows that only half of the patients feel that their doctor consistently encouraged them to ask questions or ensures they understand the answers. Um, and there are slight differences between the patients with mantle cell lymphoma and CLL, but I want to focus on the gap. And uh, some doctors allow patients to speak freely, but I want to flag that there are still barriers, and there are many patients that feel they are not being allowed to express themselves without interruption. Um, so only 66% in CLL or 56% in mantle cell lymphoma feel they can speak openly without being interrupted. So that means that 1 out of 3 patients don't feel they are fully heard. So here I really call nurses to fill in this gap and to ensure to ask proactively to patients to listen without interrupting so they end telling their story and encouraging questions, they checking understanding and allowing that space for dialogue. um, if we explore how well informed they feel, we know that most people feel fairly well informed, but many feel only somewhat informed, and they still have questions. And many continue searching for information in internet, and I really don't want to see anyone doing this alone. um, so nurses also may have a role here to guide patients to reliable sources. You were talking before about the strategies, and I truly think that Claudia mentioned all of them, but I just want to remember, I have listened nurses recommending pill organizers. Uh, and this is a very common, very practical, helpful tool. Weekly organizes with these compartments to determine which medicines you need to take in the morning, in the afternoon, in the evening. How nurses recommend to link the habit of taking their pill to another activity that is part of the daily routine, feeding your pet, eating your breakfast or brushing your teeth. Um, nurses can help set up technology reminders, alarms or anything. So they can be really filling those gaps for patients to feel not only better informed, but also better supported to deal with the challenge of their medicine and to know they can come back and ask any question. And this is part also about feeling part of the decision, feeling that the conversation is happening. And here nurses can make a real impact by creating the space for patients and families to talk about what matters most to them. It's not what matters most to the doctor, it's what matters most to the patient, and not just what the next treatment step is.
Well, thank you both, Natasha and Claudia. This was really a great discussion here. And so we've covered a lot, and we've covered a lot on adherence and supporting patients and their families, and some of the data behind where we need to do better. And so clearly, these oral therapies have revolutionized the treatment of patients with CLL and mantle cell lymphoma. We have shown that they have unique side effects. They carry barriers to adherence that really have required oncology nurses to evolve and gain expertise in educating, managing, and supporting patients and their caregivers through the journey of oral therapies. And again, Claudia and Natasha, thank you so much for this great discussion. And thank you to all of you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.